Ladies and gentlemen, I have the task to talk about the prognostic markers, and we talked already a lot about prognostic markers. So in some way, this is a bit a repetition what we have already discussed. In some way, it's a development of that what we know. Of course, we would like to know what's behind the curtain, what's under these clouds, and what we know about that, what is within a tumor, what is its biological behavior. And you know, the carcinoids, these endocrine tumors, they all look alike, you can say. So is there a difference between a tumor in the stomach and a tumor in the appendix and a tumor in the ileum, although they look almost the same? Well, this is the case. I will start again with saying that all of them are potentially malignant. This is important. Even as a tumor in the stomach, and you know they are maybe very small, can be malignant. So don't think if you have a stomach tumor, it's very small and the patient has got a metastasis in the liver, that this small tumor in the tumor can't give rise to such a metastasis. You must be aware in any location the tumors may be malignant. However, they differ in their, of course, malignant potential. If you look at the natural course of neuroendocrine tumors, and you see the natural course as a function of the growth and of the outcome, then of course there are clear-cut differences. And the differences are easily to explain. If you look at these tumors, these are usually the well-differentiated tumors. If you look at these tumors in the lung, these are the small cell carcinomas, that are usually the poorly differentiated tumors. However, you see among the well-differentiated tumors that usually those tumors in the pancreas are doing worse than those in the appendix, although they may look alike. Well, this is the first conclusion. Histologic differentiation means something. Poorly differentiated against well-differentiated tumors. Now, in the new classification, we have two types. We have the small cell type and we have the large cell type. Is this only something that is of interest for the pathologist, or does it mean anything for the treating physician? And I think, and the oncologists are very aware of that, particularly those treating lung tumors, that this has a meaning. There is a therapy, a clear-cut therapy for the poorly differentiated small cell type. But what about the large cell type? Where does the large cell type come from? Is that one group of tumors? Is that a mixture of tumors? And probably it is the later conclusion. It's probably a mixture. We see so many facets in the large cell tumors against the small cell tumors, so the large cell tumor is probably a mixture of tumors coming maybe from different origins. If you look at the macroscopy of a tumor, then you can give also, or you may have also an idea what's behind it. You never will see a poorly differentiated tumor which is as small as this one. If this tumor is detected, it is already a large tumor like that here. And if this tumor, this purely differentiated, is detected, you can't tell from macroscopy what's behind it. This can be a usual adenocarcinoma of the stomach. There is nothing different. Only histology will tell you what's behind this tumor. Here, you can make a bet. You can make a bet that this is with all likelihood, a well-differentiated neuroendocrine tumor. If they become larger, of course, that's a different question and a different story. So histologic differentiation is very important. It's a prognostic marker, and you should go for that. Now, tumor localization, and I started to show you that the tumors in the pancreas do worse than the tumors in the appendix. And there is a nice study illustrating this, a study done by Bruno Niederle in Austria with his son, and he looked at all tumors in the year 2007 that were neuroendocrine tumors in Austria. And you see the relative frequency. And he also included, that was at that time new, he also included all tumors of the stomach. That means all carcinoids of the stomach. The SEER register, you know, did not include that. So he included that, and now you see first that the stomach tumors, the stomach neuroendocrine tumors, are the most common of all these neuroendocrine tumors of the intestinal, including the pancreas. Second, he made a distinction between those of malignant behavior, unclear behavior, and benign behavior using the old WHO classification. And now you see, if you look at this, that those in the stomach, in the appendix, and in the rectum have have many benign tumors. If you look at this column here, here, and here. If you look at the pancreas, if you look at the colon, it's just the opposite. Most of them have a malignant behavior. So there is obviously a difference between the malignant or the benign behavior according to localization. You can expect it in the pancreas, you can expect it in the colon, and if we would add the esophagus, then you would see that these also almost all have a malignant behavior. There is something special in the duodenum, and I will tell you that the duodenum is a particular place with respect to the biological behavior of tumors. I will give you some examples first from the appendix and then from other parts. So in the appendix, you may have a tumor like this. It is below 1 centimeter. You may have a tumor like this. It's more than 2 centimeters. However, the likelihood that these tumors, either this one or that one, has a metastasis is very, very, very low. It's the opposite if you look at the ileum. In the ileum, you see here a big lymph node metastasis in the mesenterium. Where is the primary? The primary, as small as it is, here, is the one who gives rise to such lymph node metastasis and later on liver metastasis. So it's just the opposite. You can believe, so to say, in an appendiceal neuroendocrine tumor, but never, never in an ileal neuroendocrine tumor. The duodenum is a very special area. Why? The duodenum harbors different endocrine tumors, starting with the gastrin-producing tumor, either in the situation of an MEN1 or sporadic, serotonin-producing tumors, although very, very few. Then the somatostatin-producing tumors, either with neurofibromatosis 1 or sporadic, the gangliocytic paragangliomas, something very special in that area, and the poorly differentiated neuroendocrine carcinomas. Where are they? The gastrin-producing are usually in the bulb, in the proximal part of the duodenum. The others, they assemble around the periampullary region, particularly the gangliocytic, the poorly differentiated, and the somatostatin-producing neuroendocrine tumors. Those with serotonin are anywhere or in between. Now, we look at this large blue gangliocytic paraganglioma. And here we have such a large gangliocytic paraganglioma. They present as a polypous lesion, usually large, more than 2 centimeters. However, And I'll just show you this complex histology. It's interesting. Here you have a part of an endocrine tumor, and here you have a part of a nervous tumor with some ganglion cells and with some S100 positive cells. Well, in these large tumors, although of a size of more than 2 centimeters, usually follow a benign course. The opposite is true for the gastrin-producing tumor, particularly in the course of MEN, and particularly with a syndrome, a Zollinger-Ellison syndrome. Here's a case. It is a cartoon showing you we have got the whole pancreas of this patient and the duodenum. We started in detecting lymph node metastases outside the pancreas. All of these lymph node metastases were positive for gastrin. Then we looked at the pancreas, looking for the primary of this gastrin-producing tumors. We didn't find any gastrin-producing tumor in the pancreas, although there was one readily detectable over 0.5 centimeter in size. But all of them, and we looked at all of them, I think 200 sections or more of that, they produce anything else, glucagon particularly, and some of them insulin, others had PP, but no gastrin. Where is the gastrin-producing tumors? We found 3 of them. Many tumors in the duodenal bulb. We found also some interesting endocrine cell hyperplasia producing somatostatin and producing gastrin in the duodenum. This is the particular situation in MEN1. And this case illustrates you, and this is then one of those many duodenal gastrinomas giving rise to those big metastases. So you, with other words, you have to know where you are, where you look to, and what's in there. This is something that is something for the specialist. He has to know which tumors exist in the duodenum, in the stomach, in the appendix, and so on. Size. Size is something that is important, although you know the location is also important, but size is something important. In the pancreas, a tumor below 0.5 centimeter called a microadenoma never gives rise to metastasis. This is something, of course, I shouldn't say, because I have said all endocrine tumors have a malignant potential. But the likelihood is against 0. If it is a tumor of 1 centimeter, the likelihood is also very small that you have metastasis. Only if it has a size over 2 centimeter, then the likelihood is very high. Look at this, size matters in the pancreas. Here, these are below 2 centimeter, and it's the survival in these patients. And this is the survival in those with a tumor above 2 centimeter. You are aware of the insulinomas, and most of the insulinomas are benign, and most of them are below 2 centimeter. So, okay. However, we have seen 6 insulinomas in a series of 253 with a size below 2 centimeter, and they had a malignant behavior at or after the resection. And this is one of such a tumor, 1.6 centimeter here, the primary, and here you have the metastasis, the lymph node metastasis of this tumor. What is wrong? We said size matters. It is a tumor of 1.6 centimeter and gave rise to a metastasis. Here we have the tumor, and you see there is no infiltration. It looks well demarcated. However, going into detail on the tumor, we see that there is a perineural invasion in the tumor. This is a bad sign. This is something, if you see it, you can associate with a malignant behavior. Telling you that in this tumor with a size below 2 centimeter, there are other parameters, and you have to look for them, as for instance perineural invasion or angio invasion, that tells you something that this tumor probably is not behaving like a tumor that is in a size of below 2 centimeter. Infiltration, again, and size. If you have a tumor here in the duodenum, and it's a tumor in the submucosa like this, and you can remove it, you can be quite sure in case it is not a duodenal gangrenocarcinoma, can you be quite sure that the patient is cured? If you have a tumor like that, a size of 2.5 centimeter, and you look how the invasion here goes to the wall, this is in the stomach, then you can be pretty sure there are already metastases either in the lymph nodes or already in the liver. And this is reflected. This fact, infiltration, size, and all that is reflected in the TNM classification, in the staging, and you see how you can really stratify those tumors according to those parameters. So nowadays you have something in hand what tells you really how this tumor is going to behave in the future or already at the time of the diagnosis. And if you define it this or that way, this is a very new work by Aldous Carpa, and he defined the stage and so a little bit different. It doesn't matter. It leads to a wonderful stratification of those tumors. So infiltration, angioinvasion, size, and this matters, and this is very important. We have talked about the proliferation, and we have talked about mitosis. We have talked about the Ki-67 proliferation index. In the case of that insulinoma, I showed you 1.6 centimeter. There was a G2 proliferation grade, and this is an ominous sign. This is a sign actually of a malignant behavior. So there is an explanation that this tumor, although below 2 centimeter, behaved malignant. Coming back to the mitosis and the proliferation rate, I would again stress the point. You can count mitosis. It is okay. But it is much easier to look at this picture, and it's much easier to give a clear-cut value on the basis of a Ki-67 staining. So here you have then the grading system. You are still familiar. You are now familiar with it, and the point I want to make is the following: if you are looking for the grade, you have to look for the hot spot. You have to look for the area where you have the highest activity of Ki-67. This is illustrated by this case here. This is one tumor. It's one of the rare tumors where you have a well-differentiated tumor with a trabecular architecture at one place in the tumor. At another place, you have a solid architecture with a poorly differentiated neuroendocrine tumor. Whether this is a hybrid tumor, I do not know. Whether this is transition from here to there, I do not know. However, for the grading, it's very important that you grade them differently and that you particularly recognize this part where you have a proliferation rate more than 20%. It's 30% here, giving you a G3 level, and this is, of course, then very important for the treatment. However, if you treat them like this here, only leads to a disappearance of that part, and this one is not affected. This is another question. This is another story, and this is a story of a very individual tumor. It is also of importance to follow, you see here, the wonderful stratification according to the proliferation rate. Again, it's Aldous Carpa's work, and he set up the level from 2% to 5%. If you do that, it gives you a little bit better picture. But anyhow, whether you do it like this with 2% or 5%, or maybe we have a cutoff between, let's say, 5 to 10% and 10 to 20%. If we need it, you get a stratification on the basis of this proliferation. Now we come back to the metastasis. Here you have the liver with 3 metastases. And yesterday we heard that there is a heterogeneity in many tumors. And probably in future, in the course of those tumors, we may have to biopsy a metastasis here, a metastasis there, to see that the proliferation rate is different from one metastasis to the other, or develops over the course of the disease. So it starts with a primary here, and in the metastasis at the end it's here. So that needs another treatment than that. this is something we have to expect in future if we see more and more long courses with development of new clones in the tumor and so on. So if we do that, if we have then the crate, and if we have that, we can really have a stratification for treatment. I don't want to discuss here the treatment. That is something for the clinicians. But we heard that a tumor which is localized and which is G1 gets an operation. We also know a metastasizing tumor of G2 and G1 has a little bit a different treatment. Here maybe debulking, here no debulking operation. These are very important informations that are provided by histology, and particularly if it comes to poorly differentiated tumor, there's a difference between those, and so you can use histology as a basis for the treatment. So I discussed all these items with you, and I would like to just to say a few words what comes next and what may come. You know, SSTR, the somatostatin receptor expression, it is, you can follow that by immunohistochemistry. So you have the membranous expression of SSTR2, and in well-differentiated neuroendocrine tumors, it is present between 50 and 95%. 50%, that is particularly the insulinomas, 95% the rest of the tumors. In poorly, it's usually nothing. So there is a very good correlation between immunohistochemistry and the octreotid scan. However, in future, perhaps, we may look also at other receptors because they become important. We have the two with the highest subtype affinity among those here, but who knows? Who knows what new treatments acquire? So we have to look for new receptors, and then we have also to introduce probably a scoring system for the SSTRs, so that you have, as you have this picture, you have a score 3, and if you have almost nothing, it's a score 1 and a score 2, and maybe this is then related also to the response of the patient. So this is something we have to think about, and maybe that we introduce that in the future. Now, I would like at the end something saying about the identification of tumor origin, because it may be that we see a certain receptor is only seen in insulinomas, on gastronomas, and so on. How can we really trace back the tumors to the stem cell? Well, we did a study that had this basis. We thought that the poorly differentiated neuroendocrine tumors are close to stem cells. The well-differentiated are close to pre-programmed cells or close to terminally differentiated cells. How did we do this? We took 52 tumors and separated them by their hormone expression in insulin, insulinomas, glucagon, glucagonomas, and so on. And we looked for the expression profile of those 4 transcription factors, including NGN3. The other 3 you know. This is the expression pattern of NGN3 in a duodenal tumor, and this is the expression pattern of PDX1 in a duodenal tumor, and this is the expression pattern of islet-1 in the pancreas. Here is a control. This is an islet, which is also positive, an internal control. So what we found is, going back to that cartoon here, what we found is I first show the embryonal and then development to the adult cells driven by transcription factors. We have PDX1 for the pancreas, and we have CDX2 and MATH1 for the intestinal stem cell. We have then NGN3 and probably also islet-1, that's a little bit new, for the stem cell in the intestine, and from there it goes to the somatostatin cell, and we particularly know that NGN3 plays a role for the gastrin cell. On the other hand, we have NGN3 also as a transcription factor for the pancreas stem cell, and there's islet-1. And from there, it goes to the particular cells in the pancreas. And here you see PDX1 is a transcription factor that is particularly present in the mature insulin cell. Now, looking at the tumors, it's very interesting now. You see, we have exactly that signature in the insulinomas. We have then in the glucagon cell, whether they are glucagonomas or only glucagon-producing cells, whether they are malignant and whether they are benign behavior, we have this signature. If it comes to the PP cell and the PPomas, we have that signature. In brackets means it was not present in all tumors. However, it was present. And you see then the somatostatin cell have even a bit different signature. And then the gastrin cells, suddenly they acquire CDX2, even if they arise in the pancreas. So they have their own signature. Now look at the duodenum. Again, the duodenal gastrinoma have almost the same signature, not as frequent as here, but almost the same signature. So it seems that this is the same cell that gives rise to the gastrin cells. And the somatostatin cells in the duodenum have also almost the same signature. So first conclusion is there are individual signatures for particular tumors in the pancreas and the duodenum, particularly in this field. The second conclusion is you can't make a distinction between the duodenal and the pancreatic tumor with respect to gastrin and with respect to somatostatin. Third, you might have criteria to identify exactly tumor types in the pancreas and the duodenum in the future, and there are more transcription factors, and with using these transcription factors, we may have a very specific signature of each tumor. So I'm at the end. The conclusions are the metastatic potential depends on the different histological differentiation, tumor localization size, the infiltration, invasion, and the proliferative activity. And in future, we may have a specific targeting, or we can support the specific targeting of GEP-NETs by the better identification of the receptors at the surface, particularly SSTR receptors, and maybe that we identify these tumors by the expression of transcription factors. Thank you very much for your attention.